Okay, Venice, you can start.
Okay. Today we have a speaker from Hacettepe University Department of Prosthodontics, Associated Professor Dr. Barış Güncü. Dr. Güncü has basic and clinical research experiences on implant prosthesis. He's a fellow of Turkish Society of Prosthodontics and Implantology, International Colleagues of Prosthodontics, and International Team of Implantology. He has scientific papers published in both national and international journals, and has papers in many national and international congresses and conferences. And I'm very proud to introduce you Dr. Barış Güncü with the effect of abutment implant connection on clinical success and custom fabricated abutment production methods. Please, Dr. Güncü.
Thank you. Hello to everyone. Thank you for your attendance. First of all, I want to thank this association for giving the opportunity to talk on such a platform. And I would like to thank my dear student, Pani Sopi, who contributed and organized this presentation. Today, we are going to talk about the key points that lead us to success in modern implantology. The content of my lecture includes these topics: implant-abutment connection and its effect on the clinical success of implant therapy, the evolution of platform switched concept, the types of custom fabricated abutment and their manufacturing technique, and the birth of implant-borne prostheses or crowns or restorations. First of all, I want to introduce myself. I graduated from Hacettepe University in 2000. My PhD studies about immediate loading of dental implants. It was a clinical study. From 2013, I have been working as an associated professor in the same faculty and Department of Prosthodontics. Let's start. In modern implantology, implant and abutment connection is the most important key to long-term success and especially aesthetic success. Correct understanding and proper application of these helps to prevent biological and mechanical complications. The years when modern implantology started to gain momentum in our country is 1995 and beyond. The treatment options we offered to patients before were blades or knife and subperiosteal implants. These implants were single-block prefabricated structures. In the concept that Brånemark introduced as the milestone of implantology, the implant was a two-part system. The part that is screwed into bone is called the implant body, and the part that is screwed to the implant where the prosthesis sits is abutment. These parts connect to each other with a screw and tighten. Of course, this two-part system brought another problem: screw loosening. It's a mechanical complication that always bothers us when it comes to clinic or when the patient calls us. The solution is not always as easy as it's here. If we were lucky, we may find the screw easily. And the solution in such case is to open a hole on the occlusal surface of the restoration and tighten the screw. Later, composite is used to close the hole. Screw loosening was one of the leading mechanical complications reported in the literature for many years. Especially, a significant progress has been made in recent years. But what was the secret behind this positive development? We rediscovered America. We adopted the mechanical principle that Stephen Morse came up with 150 years ago. We adapted it to implantology. And it turned great. The amazing study done in ZIPRI showed us this. Please look closely the video. In butt joint style abutment screw connections, when the implant is loaded, the abutment is forced to separate from the neck of the implant, like this. But in conical connections, there are no such moments. Actually, the conical connection is in every aspect of our lives. Aircraft wings are attached to airframe by a conical connection with a certain length of and appropriate angle. Similarly, the vehicle wheels are attached to body by a conical connection. When this relationship is established correctly, you can simply attach the wheel of the Formula One car to the body with only one wheel range. The fans or enthusiasts know that these vehicles can go up to 3 kilometers and are used aggressively by the pilots. Nevertheless, the wheel does not leave the vehicle except for a major error. This equation actually tells us everything. The letter P stands for compression force. If you increase the length in the conical connection, P increases. If you decrease the angle, again, P increases. But what interests us as a dentist is F. The F that connects these two screws together. When you screw the abutment with the identified force, a clamping force is applied. This is called preload. Each implant brand or firm has its own identified force. While some recommended 35 Newton centimeter, the others recommend 25 Newton centimeter. For this reason, the use of torque reduces the screw loosening from 50% to 16% for the same system at 1 year. And that's why we need to use torque or ratchet to screw our abutments with suitable torques. Because the manual clamping force applied by fingers ranges from 5 to 20 Newton centimeters. As we discussed, conical connection allows the abutment to be perfectly locked on the implant. But during prosthetic application, the abutment needs to be transferred from model to mouth and back. This conical connection that is positioned, as you see in the animation video, is positioned at 360 degrees. We'll see it on the implant at different point angles each time. So we need a guide during this transfer. This guide is a geometric polygon structure. Frequently, and since the first years of implantology, hexagonal geometry is the most commonly used. We see this geometric structure under the conical connection. But the firms or the brands with time start to compete with polygonal structures. As you can see here, there are 4 types of different polygonal structures. The left one is hexagonal, the second one is tetragonal, the third one is trigonal, and the last one, the right one, is octagonal. Of course, this benefited prosthodontists more because we know today that this polygonal structure does not have a role in preserving the implant-abutment connection. So this polygonal structure helps us while transferring the abutment from the model to mouth and back. So for a prosthodontist, the minimal amount of angles would be sufficient. Let me explain this situation. It's a model. We made impression and we choose the abutments and make a restoration on it. What we will do in the mouth? First of all, we had to draw a line on the buccal side of the abutments. And while transferring this abutment to mount, we want to see that line exactly matched when placed in the mouth. If you see this line in the same position, we will know that the abutment is in the same position exactly as in the model. Please imagine that the implant has a tetragonal structure. If there is a fault, the line we drew would have a distortion, maybe 90-degree distortion. When the line is in the buccal side in the model, in the mouth, it will be in the mesial or distal side. You can see or you can recognize it very easily. But please imagine that the implant has a dodecagon or double hexagon. If we have a fault, the positioning will be only a 30-degree distortion or deviation. And it's really difficult to recognize it. As a result, the framework that fits perfectly in the model will not fit in the mouth properly. You will think that there is an impression error. No, it's wrong. It's only the positioning error. If in full mouth try-in, we spent minutes to adjust the abutment to sit as it was on the model. To be honest, as a prosthodontist, the perfect geometric shape is the least polygonal shape, trigonal or tetragonal, but not dodecagon or double hexagon. Please think it later in the future when you will choose implant system. While we talked, we fixed the connection problem, another problem emerged: biology. Now I want to talk about platform switched implants. Let me tell you that bone is a vulnerable structure in need of protection. You can never see a naked bone anywhere on the body. It's always covered with soft tissue, mucosa, gingiva, or etc. This is vital for dentists because everything we are doing involves the bone. The bone that surrounds the teeth is covered with gingiva, and they have an interesting relationship. It's called biologic width, and it's approximately 2 millimeters. We thought we could establish the same attachments with implants as well. But through the years, we discovered it was not the same. First of all, the tissue surrounding the implant is not called gingiva. It's called soft tissue. Secondly, gingival fibers around tooth attached perpendicular to tooth, but the fibers around the implant are parallel, and they don't attach perpendicular to implant. However, even though the fibers tried to surround the implant tightly, the protection was never like in a tooth, as you can see in this diagram. But from what did it need protection? One is plaque. Plaque is the number one evidence-based cause of the disease called preimplantitis. However, in implantology, there is another ethnological factor that results in inflammatory cell infiltration. It is implant-abutment connection. This theory was first proposed in 1995 by Erickson. Herman is the one who proved this theory using animal testing. Herman, in 2001, stated that butt joint style implant-abutment connections alone cause bone remodeling. In order to protect itself, bone remodels 2 mm apically. This happens regardless of the prosthetic loading. That's why, in the beginning of the implantology, a 2 mm bone loss in the first year and 0.2 mm bone loss every subsequent year was acceptable. But in today's world, it's impossible for us to accept that. We tried that. What would happen if, please look closely, if we relocate the connection inward and away from the bone? Would it help to lessen the inflammatory cell infiltration? Yes. Nowadays, instead of bone loss, bone formation is possible. A beautiful article. This article supports us in this. In the 5-year research of Wenstrom, reported a total of approximately 0.06 mm bone loss only. And continue with the same research for 12 years, a total of 0.6 mm bone loss only. It was reported. It's wonderful and encouraging. And these are my cases of short-term results and long-term results. It's really good. To sum up, the platform switched give us the following opportunities: long-term aesthetic results, encourage to use short implants, and ability to use narrow implants, because the abutment diameter is not dependent to implant diameter for platform switch concept. You can use an abutment with a diameter 5 mm on an implant with a diameter 3.3 mm. But beyond this, in order to succeed, the system itself is not enough. It needs to be used correctly. I took this picture from internet blog. It's actually a review of what I am going to explain now. I ask you to look at the picture on the left carefully. The neck of the implant abutments. Emergence profile, the margin located 1 mm below the gingiva and the crown on it, the left side. All these ensures aesthetic and long-lasting biological emergence profile. We call this part the transition zone. The recommended length of this zone is 3 or 4 mm. I can explain this a lot easier like this. A platform switch implant needs to be placed 3 mm apical to cemento-enamel junction of the adjacent tooth. In other words, implant should be placed 3 mm apically of the cervical margin of feature crown. What's feature crown? The crown that will be placed on the implant. I want to show 2 example cases. In my opinion, they are bad cases. When we first look at the implant, the problem may seem the close position of the implant to first molar. But if you look closely, we will notice that the vertical position of the implant is wrong. Unfortunately, 50% of the implants were placed like this. And in such case, in order to make the clinical crown length of the implant the same with the adjacent teeth, you must make the ceramic bigger, but it will be our biggest mistake. We need to make a perfectly fitted crown. Unfortunately, the crown we made has an insufficient crown length compared to adjacent teeth. In the mouth, this aesthetic problem strikes to eye too. Our only solace is that the crown we made according to the rules would stay in the mouth and preserve the bone for long years. But the patient will not have a papilla. Never. Please never forget the rule of 3 millimeter. Let's see the same mistake in anesthetic zone. She's a young lady. In this picture, it may seem that our biggest problem is the angle, but the research has shown us that the angle has no negative role in preserving the margin of the bone. This patient also has a similar vertical problem. In my point of view, the surgeon misunderstood the 3 millimeter rule, and he have applied the 3 millimeter rule inversely. Please look. Then let's see what will happen. A screw mountable crown, it's really bad. But the prosthodontist can do nothing in this situation. If the surgeon used a shorter implant and placed it in a deeper position, everything will be perfect. Hello to everyone again, and I want to say that you will be an oral surgeon, you will be a periodontist, or you will be a prosthodontist in the future. Please do not forget this picture, and do not forget this rule of 3 millimeter. And for me, the most important take-home message today is this one. Let's go on. Of course, a good example. Please look. A missing lateral tooth, an implant will be placed. At the end, there will be a crown here. Am I true? Yes. What says the rule? The implant must be positioned 3 millimeter apically to the margin of the crown. It's true. If you make an implant that conforms to the 3 millimeter rule, you have the chance to achieve aesthetic excellence. Like this. In the first part, we have discussed implant-abutment connections and their effect on clinical success. So what advancements and updates have occurred in prosthesis part? Which one is more successful? First, I want to ask a question that we all look for an answer. Which one is more successful? I'm sure everyone has an answer to that question. But actually, it doesn't have an answer. It's a gray area in implantology. What do I mean? Usually, the answer is this: cement is bad. Is it actually like that? This literature does not support us. More literature can be discussed. So what's the problem? Yes, cement is bad. Unfortunately, why? Unfortunately, because of our busy lifestyle, we try to do cementation during the short time between two patients. For example, while a patient is waiting, we tend to cement a full mouth restoration. And because of that, we do it carelessly. I do it myself from time to time, and each time I regret that I have done it. Let me show my cases. These are my cases. Why cement is bad. The first case. Please look closely the X-ray. You will see that the crown does not fit properly on the abutment. Patient told me that, hey doctor, I have a problem. I feel it's not comfortable as we tried in. I said, no, it's the same restoration I tried in. And I argued with the patient. Then I sent him to take an X-ray. I saw that he was right, the patient was right. The crown did not sit properly. This was probably because I made the cement more viscous. This case, you can see the cement residue on the mesial side. I am lucky to see it in X-ray because we know that cement residue usually is seen on the buccal side. I am really lucky. This patient has lost the implants that placed with sinus lifting. The patient was smoking and there was a problem in his osseointegration. Maybe I did not have any role in its loss, but I have cemented these restoration. And it made me sad seeing the residual cement here. This is the patient that came to me with screw loosening. When I opened a hole and screwed the crown, I saw cement residue here on the abutment. I am showing you all these to point out that your experience has nothing to do with the issues in cementation. And every cementation should be done like a dentist who just began carefully. Cementation always requires attention and thoroughness. No matter if you're a dentist working 5 years or 10 years or 50 years, cementation is as important as preparation, impression, and porcelain fitting. Of course, many studies have introduced different methods to reduce cement residue. One of them is done, I think it's from Frankfurt University, Paul Weigel. It recommends the use of abutment duplicate manufactured from pattern resin in cementation. It's an easy way to control cement residue, especially for single crowns. You can find similar innovations in this kind. But what's the best solution? Screw cement retained superstructures. We will talk about this. It's called titanium-based crown, implant-borne prosthesis, screw cement retained superstructures, or screw mountable crown. All of them are in the literature. But before getting to screw cement retained superstructures, I want to talk about the abutment production methods, custom abutment production methods. The companies, of course, give services like fabricated abutment productions, as you see here. Fabricated abutments or stock abutments mostly do their job. Different gingiva heights, different platform diameters, angled and anatomic abutments you can find, of course. But sometimes we need custom abutments. Such a case, a very easy case, but in clinic, we usually deal with two different situations at the same time frequently. Upper jaw, edentulous ending. There is an adjacent tooth in the anterior tooth, in the anterior implant, and increased interocclusal distance in the posterior implant. You will never see a curved morphology like this in the mouth and increased interocclusal distance. This can be solved simply by custom abutment protection. It's really good. Unfortunately, there is no option for stock abutments. Please look the curved morphology. So what's the methods for production of custom abutments? Custom abutment production has been used since the beginning of implantology. The first of such abutments were cast abutments. Cast abutments, you can see here with the yellow one, have two major disadvantages. First, precious metal alloys are needed, which increases the cost. Second, it needs technical precision. That's why nowadays we don't use them or prefer them. I will be talking about the two other methods, prefaced or pre-milled and titanium base. When choosing an implant, when choosing an abutment, these are some textbook information that one should know. But the most important one is probably the perfect fit to implant. I have showed you a formula, an equation at the beginning of the presentation. I forgot to mention something there. Well, to be honest, I left it for this slide. For the equation, it's a must that these components should fit perfectly. Otherwise, length, angle, force will be nothing. If you don't provide this perfect fit, for short term, you can save the day. But for long term, we are doomed to live with mechanical and biological failure. Original connection can be achieved if the company shares the information of the implant with you or provides services or instructions. Of course, custom abutments are not a new thing. Companies such as Straumann, Astra, Nobel Biocare have done this a long time ago. Matt Anderson has introduced Procera 36 years ago in 1983. But the biggest disadvantages that they got is their price and accessibility. Producing an abutment with this system is even more expensive than the implant, and accessing them was an issue for many countries. How we solve the problem? I want to show you a video how implant and abutment are produced. I took this video from Discovery Channel, how it's made show, as you know. Even though the companies try to compete, there are only a limited number of companies that produce titanium, and everyone buys the titanium stake from them. The difference is achieved in fabrication, connection, and surface characteristic. And companies obviously do not share the specific geometric or mathematical ratios. In this video, an implant produced in the milling center, as you see. First of all, the outer surface of the implant was milled, and after that, the inner part of the implant is milled. It's really easy, but you must know the mathematical ratios and geometric ratios. Here are this one is the left side titanium stick, implant milled and finished. So how we solve the problem? Again, companies can produce the part of the implant that sits on the implant and leave the rest untouched, as you see here. In the bottom, the abutment, the important area that fits into implant, is made by manufacturer, and the rest leave untouched. So You may mill the rest as you wish, like this. This is called pre-milled or prefaced abutment. In my opinion, it's very clever idea. All you need to do as a dentist is to approve the design. You can also make the design yourself if you have time, of course. Later, the only thing left is milling. The pre-milled abutments that you see here attached to a piece called holder. Every prefaced abutment does not work with every holder, so there are many brands to choose from. But there is nothing to worry about, as the companies provide help with all these issues. Let me ask you a rhetorical question. When can we use them? The answer is in any cases. Of course, it's more beneficial to use them in every case, and in the near future, it seems plausible because the companies will prefer such manufacturing compared to producing different type of stock abutments. A case. I want to show a not-only case about this, a full mount case. This case was not done in our faculty. The patient has 7 implants in the upper jaw, but unfortunately none of them obeys the rules of facial aesthetic. The patient was not asked of what she wanted. The patient wanted was having a removable denture that was easy to clean. A nice smile aesthetic. As a result, patient-doctor trust relations were harmed. For both fixed and removable dentures, the implants are not positioned correctly. When considering overdenture, such types as bar or ball attachment is not an option. Only one option is left now: telescopic retained overdenture. And for telescopic retained overdentures, all we need is perfectly parallel abutments. The thing that could be said for this picture, it can be only possible with custom production methods. We make wax-up model on impression and we design the abutments. And now there's nothing on our way to do perfectly fitted prosthesis. I ask the patient to keep the dentures in the mouth to show you the perfect fit of the overdenture on the abutments. Please look closely the right side. I want to show you a case. It's my dream. What will happen? Let's see. We placed an implant with a diameter of 4 mm here and planning to make a crown with a mesiodistal length of 12 mm. What happens if you make a customized abutment that resembles a prepared tooth of first molar? In my point of view, it didn't succeed. I didn't like it so much. The thing I didn't like was that there are no interdontal papillae. This was not my intended outcome. I wanted a crown with a beautiful emergence profile. Let's keep working. Another try, another patient. I asked the patient for permission to recontour the gingiva for 6 weeks. Patient agreed. The beginning, temporary crown screwed on the implant, 5 minutes, 6 minutes, 10 minutes, 6 weeks, and after recontouring. The impression procedure that duplicates the shape of soft tissue and custom fabricated abutment resembling a prepared tooth form. After 3 years, it's really good. But do we need to produce custom abutments from prefaced abutment in such cases? It was a question that had bothered my mind for a long time. No. Now I know the answer. No, we don't need to produce custom abutment from prefaced abutments in such cases because we have another option called titanium base. Let's look. Similar patient, a missing first lower molar, recontouring, impression, and this is a monolithic zirconia crown over titanium base. It looks good. 1 year later, we upgraded this a bit. This case I will show is not an evidence-based case. It's more like I did it and it worked. But we are continuing our research and hopefully one day we will publish it. This is an example case that we finished the crown on 2 appointments. In first appointment, we made an impression and using a digital or traditional impression method, it doesn't matter, we recontoured the model or virtual model according to the smooth concave profile concept, finish the crown, and screw the crown and close the hole with a composite resin. Buccal side view. It looks great and much more easier than the previous one. I talk about tie base or titanium base, but what's tie base? I want to explain it. Zirconium came into our lives almost 20 years ago. It's a great material. Even zirconium implants are being produced. Of course, it still needs to develop, but we know it will have an important place in the future. It came to modern implantology firstly as abutments that allow aesthetic results and biocompatibility. And I start to work with them. Firms or brands supported and encouraged this, but some things went wrong. I want to show my case. It's a very good example. Please look. This is the case I did in 2007. After 10 years, in 2017, the patient called me. Hey, doctor, the bridge came out. I called the patient to clinic. As you see here, some pieces of bridge, cervical margin of the lateral tooth, was broken. Please look the abutments. The left one looks healthy, but the right one is a bit shorter than I remembered. So I took the abutment out. This was the result. It was broken. But this was not the only negativity. Please look closely to the abutments I took from the patient's mouth. You can see grain stains. What are those? These are corrosion residues of the inner part of the implant. I am not the author, but I am going to show you a research. It's an interesting research. When a titanium implant is loaded with zirconium abutment, the inner part of the implant wears off. You can see the before-after pictures. The inner part of the implant, please look to the left side. The implant is changed after 5 years because the inner part was worn. Please remember the equation of abutment-implant relation. this implant may never serve as it could have. And this is the picture of loading the right side with titanium abutment. We can't see any disruptions. It's still good. Then firms offered a new alternative. It's a hybrid abutment. This part is titanium, and the first left side full zircon abutment, the right side hybrid abutment, the bottom of the abutment that fits in the implant is titanium, and the upper part is zirconia. The first products were introduced to market like this. Later, the firms changed their minds and they started to sell these kind of abutments, as you see in the bottom left side. They sell this kind of abutment and they told us produce a zirconium abutment or prepared tooth shape zirconia and cement it on the abutment and use it like this. This is my case. We use it. But later, they changed their mind again. They said that do not make abutment, make crown directly on it and cement the crown extraorally with resin cement and screw the whole structure on the abutment. Of course, there is scientific evidence behind this. This is called titanium-based crown. An example for the scientific evidence for these kind of superstructures, the comparison of different types of restorations fabricated on titanium-based abutments revealed that one-piece crown, as you see here or in the bottom right side, has the maximum fracture strength. Near to the end, I want to explain the advantages of titanium-based abutment compared to traditional cement-rotated abutment. Titanium-based abutment looks like cement-rotated abutment. It has gingival height options and two different chimney height options. But when you look closely, you may see the microscopic geometry. This geometric property provides the following important advantage to abutment. This is it. 3.5 millimeter chimney height equals 7 millimeter and 5.5 millimeter chimney height equals 11 millimeter. This allows us to use tie-based abutment in a wide range, especially if the interocclusal space is insufficient. My last case I want to show. It's an interesting case. Why? Let me explain. First, I want to say a motto. The person who doesn't know what he is looking for, he does not understand even if he sees. The patient came from out of town and she went to many dentists before me, and all of them said the same thing, that this implant was placed wrong and needed to be taken out and or replaced, or they had to extract the canine tooth, lower canine tooth, etc. I said to the patient, I will only strip 1 millimeter from your lower canine. I won't replace your implant, and I will make a great crown for you. Of course, the patient did not believe me because all other 10 dentists say the same thing to the patient. So, what had I seen? Let me show you. This is the healing abutment. Healing abutment had 4 mm length. It's written here. It means that the implant was here. It's in the right position. As we discussed earlier, 3 mm deeper than the feature crown. And if we put a 3.5 mm titanium base abutment and stripped 1 mm from lower canine and make a modified zirconium crown, everything will be excellent. Additionally, the horizontal position of the implant is also perfect. We didn't discuss today, but maybe in the future. It's in the cingulum position. I asked permission to take an impression and make a temporary crown. This is the temporary crown. When I first inserted, of course, ischemia happens and wait for 5 or 10 minutes and everything is normal. This is after healing. 6 weeks later. As you can see, there are some remnants of grafts. I asked a periodontologist if it will be an issue. The professor said me that if you are not going to make a cement retained crown, let it stay. I said I was doing a screw retained crown. Any impression of the formed soft tissue, and we made a titanium base bilayer zirconia crown in occlusion. Everything looks great. After 2 years, it's still perfect. It doesn't bother the patient at all. Updates in modern implantology aim towards more aesthetic and long-term bone soft tissue stability outcomes. We need to follow these innovations and apply them correctly in our clinical practice. Thank you so much for your kind attention.
Okay, thank you so much, Dr. Barish, for this amazing webinar. I'm sorry, I was muting my mic. Now, I would like to check if we have any questions today. Okay, so we can wait 1 more minute if there's any questions coming from the students.
Do you have any questions?
I think not yet. It's all about like master.
Of course, everyone can send me email. I use this email every time.
Okay.
Thank
so
you.
okay, I think we will not get more questions here on Facebook or on the YouTube streaming. So thank you so much, Dr. Barish, for amazing webinar today. It was really informative for me, and I believe it was the same for all the watching students and the ones who will come and watch it later. Thanks everyone for your time and your attention, and thanks again, Dr. Barish, and have a nice day.
Thank you. Have a nice day. Bye.